Welcome to Health Wonk Review on Air. This is David Harlow, otherwise known as Health Blog, coming to you live from Boston, Massachusetts. And this is our third edition, and I'm happy to bring this continued experiment live to you. So, Joe Peduta, my regular co-host, is unable to join us today, and we have others who are going to join, I hope. We're experiencing some technical difficulties, but we hope to get rolling with another co-host shortly. In any event, you'll have the pleasure of listening to me blather on about some recent Health Wonk Review posts. So the most recent edition was hosted by Brad Bright, and the link is in the sidebar. We'll be looking at some of the posts that were collected in the most recent edition. And if you have any particular comments or questions you'd like to add to the discussion, please hop in. Also would like to let you know that we do this every 2 weeks, and I'm going to drop a link to next week's, the edition coming up in 2 weeks from now will be dropped in the sidebar there, and I hope you follow that and subscribe to that, and we'll catch you in another 2 weeks. So, for today's discussion, I wanted to start with a post on Zika preparedness that was included in the most recent edition, and it was drawn from the Health Affairs blog, co-authored by Alexander Phelan and Larry Gostin. And the issue raised here is the issue of preparedness for a Zika outbreak, and the question of how do we balance preparedness in the abstract with actually being able to deploy resources. I mean, there are funds available. We've been able in the past to deploy funds against the West Nile virus. Other governments in other parts of the hemisphere have been able to deploy resources in an effort to roll forward and try to get ahead of the Zika virus. And the question is really, can we do it? There's a significant funding request, an emergency supplemental appropriations request of almost $2 billion was put in by the administration. Most of that is for HHS, and much of that is for the CDC, and part of that is for vaccine development and commercialization. Part of the issue, I think, in dealing with an issue, a problem like this on a national basis versus a local basis, is that there are so many layers of government and administration involved, and sometimes the collaboration, the cooperation is very difficult to pull off. And frankly, in order to deliver any results, requires permissions at local, state, and federal levels. It's sometimes difficult to see how an individual municipality, let's say, can take steps without getting permissions at the state level, and sometimes the state level can't proceed without getting permissions at the federal level. I think about this sometimes when we look at problems with infrastructure and our crumbling infrastructure. Often development projects, redevelopment projects cannot necessarily take place, cannot get off the ground without a tremendous number of, say, environmental sign-offs or other sign-offs that are required at the local, state, and federal level. And I guess I'm concerned that maybe this is part of the broader issue. I think the Health Affairs post focuses on congressional delay issues like that, and in addition to this sort of local versus central control kind of issue. And I think we can probably extrapolate this to many other healthcare issues as well. There are potentially tremendous federal dollars available or hoped to be available to address certain public health issues, but there's required a tremendous amount of coordination at the state and local levels as well. And if that is not forthcoming, or if the federal appropriation is not forthcoming for a variety of political and other reasons, then we can't really get anywhere. So, moving forward, I'm going to set that post aside, though I'm certainly would more than welcome your input and comments on what is happening in that arena as we proceed. But moving along here, let me see if I can pull up the next post that I wanted to highlight here. Hang on just a sec. So next up, in the realm of the health reform implementation, on the health reform implementation front, Joe Peduta put up a post this past week talking about whether there would be an impact on employment from implementation of the Accountable Care Act, right? To the extent that the Accountable Care Act requires availability of health insurance regardless of regardless of employment status, the expectation was in certain quarters that there would be a reduction in employment at the margins. People are in the workforce simply because they have to be in order to obtain health insurance. Then, again, the expectation was that there might be some drop off from, drop off in employment. And there was some criticism there that, that would be the case. To be fair, the Congressional Budget Office predicted a small negative effect on employment. And in fact, thus far, there has been very little effect to the, up until now, we're looking at maybe a prediction of 2%, 1.5% to 2% in total number of hours worked being reduced, maybe 1% total compensation reduction. And really, the longer-term reduction in work is expected to come almost entirely from a decline in the amount of work that workers choose to supply in a response to the changes in these incentives. So it's not really accurate to say that this is a job-killing act. And in fact, we've sort of seen this play out thus far. There hasn't been that much of an effect on the employment front overall. If others have any thoughts or any figures on this front, I'd be happy to hear from you. But that's what I've seen thus far. Moving along here, there was a post in the last edition regarding non-healthcare folk being on hospital boards and the tremendous amount of time and effort that it may take to educate people about the healthcare system and about delivering healthcare services. In the current edition, one of the posts anthologized is a post by Jan Sidorov on the Population Health blog, looking at governance advice for hospital boards coming from Michael Jelinek at the Leahy Clinic. And the questions there are really around, what can the board do around population health? Are there forces running in opposition to each other? Will a board go against its own interests, if you will, in trying to promote population health? Are hospitals still focused on the fee-for-service model? Can a hospital standing alone go beyond the fee-for-service model and embrace population health with all that that entails, including a reduction in fee-for-service income? So, it's an open question. It's a continuing issue. If you listen to the folks at HHS, you will hear that there's been tremendous uptick in the implementation of non-fee-for-service payment mechanisms and a move away from the imperatives of the fee-for-service system in delivering healthcare. So let's see here. Thought Peggy was trying to get in here. Trying to unlock a seat for her. Shouldn't be locked. Well, let's see. Lock, unlock. Hopefully Peggy can get in this time around. And here she is. Okay. Hello, Peggy. Hopefully I can hear you, but I can't see you.
Hi, David. Can you hear me?
Yes.
Yay!
You made it.
We're on our third device. The smartphone and the laptop didn't want to do it, but I'm on my desktop. Unfortunately, we don't have a camera on this, but hey,
okay.
We'll make it happen next time. Hi, sorry for having you out there.
Excellent. No, it's always wonderful to have an opportunity to pontificate about health policy without being interrupted by anyone. But welcome. Thank you. Glad you could join us today. So great. I've been blathering on about a couple of the posts collected, and I'm just going to finish up talking about Jan Sidorov's post on population health before turning to the post that you had submitted to the current edition dealing with MACRA. So, the key issue for most hospitals is the dichotomy between fee-for-service and population health, doing things that promote population health that may be against the short-term interests of the individual hospital. Obviously, we need to invest in primary care, care coordination, teamwork, pursue more population health pilot programs that are being rolled out faster than we can learn the acronyms from CMS. Peggy, I wonder if you'd care to jump in on this topic as we transition from this to a broader discussion of what's happening now on the CMS rulemaking front.
Yeah, and I'm really sorry, David, that I didn't get to hear everything you were saying while I was playing with my with the technology. But actually, you talk about the rules and the laws coming up faster than we can come up with acronyms, and I think that is really something that is a huge issue for us. I think we're coming up with so many laws and rules and acronyms that doctors who get into it because they love medicine and they love patients and they want to practice medicine are really spending most of their time learning acronyms, worrying about getting paid, worrying about documentation. And I sometimes wonder if we're not defeating the whole purpose of the system itself. That I think is my concern. I may have gone a little bit off the road on that, but that's what occurs to me when I think about the massive amounts of legislation and amount of paper that could choke a horse coming out of Washington. And are we really accomplishing the goal?
Right. So, I mean, for many providers, there's a consistent desire to stay focused on the triple aim or even quadruple aim, as some have put it, And there are always trade-offs to be made. And I think for many institutions, the problem is, can we afford to make an investment in IT systems, analytics services, and others in order to try to participate in some of these bleeding edge new payment initiatives, alternative payment models. And for some providers, the answer is still no. CMS is trumpeting the fact that, some providers are jumping on board. I think we're in the 30% range of people looking at alternative payment methodologies. But clearly the MACRA rule is directed at moving more and more physicians in that direction. So with that, I'd like to ask you to speak to your post about the MACRA rule and the issues that you see there.
I think that, first of all, we had some great meaningful use ideas that were rolled out in an attempt to try to get a good, viable electronic health record across everyone, across all the sites of care, across all the patients, so that all the providers could access it, researchers could access the data. All a great idea. I sometimes wonder if we weren't a little bit aggressive in trying to force, with incentives and disincentives, providers who just weren't there yet to make it happen. And I think we've accomplished some things. I think, what do we have? About 90% of providers now have some kind of electronic health record system because they were forced into it. So I guess there's something there for that. But at what point have we begun to put too many rules and regulations around it and made it too cumbersome? So the answer to MACRA is, perhaps MACRA is an attempt to try to simplify that, maybe have a few less quality measures, maybe simplify meaningful use just a little bit so that people might stand a chance of being able to meet some of those targets. But I don't know that we're still there, and that we still don't have, I think, 962 pages of new rules that physicians who are trying to practice medicine are having to meet. And I don't have the answers, but I think we have a very clear problem of complexity. And Part of I think what happens is we're coming up on the government funding, 50% of healthcare now? And I think by around 2020, we're looking at healthcare being almost 20% of GDP. That's a pretty big chunk. And so at some point, if government's going to pay for it, they're going to make sure they're going to get their money's worth. That makes sense. And we want to make sure patients are getting what they need. I just, again, I'm concerned about the complexity and the effect on patient care when it, at the end of the day, and that's an overused phrase that I don't like hearing coming out of my mouth, but really what happens when there's a patient in the bed and it's really about what's happening between the doctor and the patient. I think a lot of these rules are getting between those two people.
Right. Well, I mean, the MACRA rule, of course, is presented in order as part of the replacement for the sustainable growth rule, which was a disaster. Sort of made sense for a brief shining moment, and then sort of devolved into this annual or even more frequently than annual exercise of overruling the rule. So the MACRA, the MIPS approach is intended to replace all of that. And CMS has been delivering the message loud and clear that this is really part of a broader push. And it's pretty clear from the rule that the intention is to move providers, in this case physicians and physician groups, away from fee-for-service medicine, which in the abstract, I think we would mostly agree is a good thing. We want to sort of trade value for volume, right?
Correct. I think when we encourage volume, that's what we get. We get volume. We get more tests. We get retests. We get third and fourth opinions, and people, doing that, having more incidents of care to charge for. And yeah, SGR was a joke. I mean, when did they pass that? 97? And every year it was just, we'll just pretend that didn't happen.
Right. Yes.
So SGR did sort of become a joke. And this is a replacement. The question is this an effective replacement? And
And I think
I
it's,
think
frankly, it's hard to
MGMA is
answer.
really.
I'm sorry, go ahead.
Oh, I'm sorry. I stepped on you. Yeah, no, MGMA is worried about that. They're looking at the fact that this is pushing small group practices and individual providers, pretty much pushing them out of business. And they're saying that 80% of groups of 24 physicians are under, considering a small group, are, could put them at a disadvantage. They're going to end up losing money under this. So I think MGMA has some serious concerns about the viability of something that's this complex when you're looking at, 5 cardiologists trying to practice medicine in Iowa or something. I think we have to think about that.
Right. I think CMS was straightforward about that in the rule itself, and they identified that impact. But I think, worth mentioning that I believe reflects the impact on smaller groups if they choose the advanced alternative, the APMs, the alternative payment methodologies, the more non-fee-for-service payment methodologies that are available under the rule as an alternative. Perhaps over time, it is in fact the intention of the agencies to move folks in this direction. Although I wasn't there and I didn't hear the details, I know Andy Slavett was at a professional society meeting in the past week saying that no, that's not the intention of the government. It'd be interesting to hear more specifically what he has to say and how that aligns with the projection, again, even in the rule as published, that this would have such an effect on smaller groups. I think we need to be moving in this direction one way or another, away from volume and towards value.
Yeah, and I think the whole movement towards population health it makes a lot of sense because we can manage populations and some of the broader brushstrokes probably more economically than attacking each individual patient. And I think that now we have the technology to be able to do that, to be able to push out text messages and be able to manage patients and groups. And I think we can do things like that in a more cost-effective way. But we're not there yet. I think that's it. Is that we're moving in that direction, and I think some of these laws are going to get us closer, don't you think? But it's just going to be a little messy between here and there.
Right. Another comment that I've seen out there in the past week or so since this rule was released is, hey, the government had a year to cook up a 1,000-page rule, and now you want us to digest and comment on it in 60 days? I don't think so.
That's true enough.
Right. And it certainly wouldn't be the first time that something like this has happened. I actually heard a government official today being asked, why haven't we seen an implementation yet of the accounting of disclosures rule under HIPAA? That's something that was published as a draft rule 3 years ago now, and there were comments filed, and ultimately the rule was withdrawn. So here we are, years later, and we don't even have that rule. So it's certainly possible that we'll have an extended waiting period before we see a final version of the MIPS rule under MACRA, even though there is a congressional mandate to have it implemented by a date certain. That doesn't always happen, even if Congress.
Yeah. Now, how many times have we seen timelines moved out? And it's I guess what's the reason for moving them so close? And most people probably know unrealistically. Is it just to make sure that we start to light a fire under people? I don't really know, but we see the move out lines so often. You often wonder, what are they thinking?
Right.
But yeah, I think too, with just to go a little bit back about APMs and having the choice between, you can either go, you can be paid under MIPS or you can choose an APM. I think I saw a statistic within the last day or two that they think about 10% of providers are going to choose the APM, but there's a downside risk. that a lot of people just aren't set up to accept that kind of risk yet.
Right. And to date, many of the ACOs, MSSP plans, et cetera, have not taken the downside risk, even though the upside risk is then greater. The potential benefit is greater. So it'll be interesting to see how that plays out. And frankly, some providers need to make a decision about whether they're going to, participate on the assumption that this will, in fact, be active for calendar 2017. You're going to have to act fast and make a decision and decide whether to opt in.
Yeah, and it's amazing. And interviewing doctors for a project last week, finding that there are physicians who don't even know what MIPS is yet.
Right.
And as of January 1, what they do next year, you're right. It's going to count toward getting paid in 2019. Right. So they need to get their act together. And what the final rules coming out in the fall. So it's really a matter of having a couple of weeks to figure out what you're going to do.
Right. So Peggy, other posts that caught your eye this week?
I thought it might be fun to talk about a single payer. I saw somebody talk a little bit more about single payer, and who's doing that? Somebody. I'm pulling up somebody's blog. I saw single payer, and I think that's always an interesting topic. Is it possible?
I always say when Ted Kennedy said publicly that he was giving up on single payer, I figured that was it.
Yeah, well, I guess what we have here is, because of the political environment, we have Anthony Wright of Health Access California offers a suggestion for moving the country towards single payer. He writes, the great primary debate on health reform had some missed opportunities, but Senator Sanders seeks to influence the party platform and could spell out concrete steps, some that California has implemented or is considering. And the other day I was talking to a Frenchman, and he was decrying our medical system in this country. Mm-hmm. He said, if we get sick, we just go to the doctor. Here you need insurance, and it was so cumbersome. And he said, it works beautifully. He finds this very unwieldy. So just kind of wondered what you were thinking about that.
Yeah, well, I mean, Bernie's plan got raked over the coals this week. The latest panel of independent experts, whatever that means, said that he would basically double the national debt in the course of implementing his program. All such projections are bound by the various assumptions that are included. And the retort from Bernie's camp was that they made basically more, they made what they felt were more realistic assumptions, and the naysayers thought were more, overly optimistic assumptions about the openness of the U.S. as a whole to such an approach. They say you can't really compare implementing something like that starting from scratch in the U.S. to situations in Europe and Scandinavia, let's say, where that's just sort of been, the way things work for decades and decades. And people expect it, and people live with it, et cetera. Here, there'd be a huge impediment to getting off the ground from a variety of directions, don't you think?
Oh, I certainly do. Yeah, there definitely.
Mm-hmm. I mean, not that it's necessarily a bad idea. It's just possibly unimplementable.
And we have a complex system. That's exactly right. And it would be, and look at this on almost a state by state approach. Mm-hmm. Might be the way something like that would fall, where it would be a domino, starting in small places where it might be more workable. And, and I don't know that I've ever been a proponent of something like that, but I have to look at how really complex it's becoming. And at some point you wonder if we don't need to back away from the incredible complexity that we have and try to find a simpler way to get healthcare to people. because it's become more business and less health. And I think that's what doctors are complaining about.
Right, right. Well, as you said, we're moving towards a point where we're going to be spending 20% of GDP on healthcare, and it's worth questioning whether we're getting quality for that dollar. And there ought to be a better way. So one of the reasons why single payer is attractive is because of a reduction in administrative overhead. But there are certainly other European countries and other countries in the world where there's something in the middle. It's not necessarily a single payer system, but there is universal coverage through a number of insurance trusts or other mechanisms. So there's certainly other ways of addressing this, achieving universal coverage without necessarily going for a single payer system, because that just seems to be, un-American or socialist or something.
Exactly. Those are the conversations. I saw two economists, one very much for it, one very much against it, nearly come to fisticuffs in a in a conference one time.
Yeah.
So people feel very passionately on both sides of this issue.
Oh yeah, absolutely. Well, great. Well, I see we're at the bottom of the hour here, and we advertise this as a 30-minute blab, trying to respect people's time. And Peggy, I thank you very much for joining in on short notice today. And I look forward to continuing the conversation with all of you on and offline. We will be back in 2 weeks for Health Wonk Review on Air. I've dropped a link to the upcoming blab in the margin. And I am also going to drop a link to a blab that I am hosting on Friday of this week concerning privacy and security of health data. Two recently issued reports, one from the Brookings Institution and one from the Ponemon Institute on the topic, and I will be speaking with the authors of both those reports and invite you all to join in, invite you all to check out my blog post with links to the reports in advance and come armed with some questions and comments. Again, thank you very much, Peggy.
Thank you very much, David.
And thanks everyone for dropping in. See you next time.
Have a good one.